Good morning, Marko.
Hi.
Hi,
Kornmann, Andrey. Andrey.
Good day.
Good day. The problem is I'm on the train, you know. I'm on the train, so I'm worried about the transmission signal. But I'll continue to train to Beijing. Marko?
Только you should.
Marko, are you busy now? What about the department? Marko? Kornmann?
Marko, we don't see your icon of microphone. Maybe your computer any trouble. Oh, now we can see, but not. Oh.
Can you hear me now?
Yes. Yeah, now we can hear you.
Good morning or good afternoon to China.
Yeah, here we are. Yeah,
Hi.
it's 3 o'clock p.m. That's right. So I'm on the train, the fast train. It's not traveling, but a business.
Okay.
So, Marko, what about the department situation? Anything settled down or not?
2.5 years ago, Christoph Michalski came to Ulm and took over. And actually, we managed that he followed Markus Büchler in Heidelberg, and he applied for his position in Heidelberg, and he started in Heidelberg 1st of April this year. And actually, we had another guy who take over the position in Ulm, but he moved to Tübingen and took over the University of Tübingen. Okay. So I'm at the moment
you are in charge of
so I'm in charge. Yeah,
good.
And it will probably take 3 to 6 more months we have one guy from Mannheim who is in negotiations, and he will take over maybe in end of the year. Yeah.
A lot of chance.
That is the situation here in Ulm. So we not have a lot of, or actually, some people left to Heidelberg. So we have to fill up our staff with new people. So it's quite busy for me. A lot of operations I have to do.
Yeah. 2 weeks ago, so I visited Serbia, Belgrade. So I met Simon, Simon, but not the guy, the originally working in Heidelberg, and it's in the Switzerland, I think. Simon, know that, that guy. He took me some information about the Chinese university.
Your voice at the moment is difficult for me to understand. I'm sorry.
I'm sorry. I'm on the train, so I didn't speak loud. So two weeks ago, I visited Serbia, Belgrade, at a meeting. I met a guy, Simon. He's left of Petersburg to Strickland. The guy.
Yeah.
You knew him. Yeah, you knew him. Yeah. So
I know
he told
him.
me something about information about the situations of Petersburg.
Very good. Yeah. So actually, we do more and more, robotic surgery, and that is getting more and more popular. So if you apply it, university hospitals, I think at the moment, for these chief positions, you need to show that you are able to do some kind of robotic surgery. Yeah, that's what they are doing in Heidelberg more and more, I think. Yeah, and also in Tübingen. Yeah, and we too here. Okay. So Andrey, thank you very much for organizing. Yeah, before we start, do a lot of effort in this again. So thank you very much from here.
Yeah, we should keep contact and
of course.
keep activity.
Yeah. Actually, with China,
Hello, good morning.
Hello, yeah, please.
Alles Lauscher.
Jörg is also from Berlin, right? Jörg?
Yeah.
Yes, we are both from Berlin. Yes, that's right.
Yeah. So you work in the same hospital? Huh?
That's right. Yeah.
Nice to meet you.
Nice to meet you too.
So, traveling China, is it now open again?
Yeah.
Traveling to and from China? So you don't have quarantine anymore?
No.
Okay.
Everything's gone, Last few months it's gone.
Okay, very good.
All the situation is very open. Those people who wear the mask, not necessary. So I think it's a normal life now. It's good.
Okay, that's good to hear.
We have a chance.
Yes.
Yeah. The problem is, getting the visa is a little bit difficult because in the next month, I think Pitner and some other guys will join a meeting about any Cologne because they have German holiday days. Yeah. But we would like to go, but the problem is applying the visa. To take long time because many people want to travel.
Okay. Yeah.
Marko, it seems to me we can start. Time to start.
Okay. Yeah.
Okay.
So, colleagues, it's a pleasure for me to open this online seminar organized by the International Colorectal Cancer Club, and basically organized by Andrey, Ivanov, and Yin Lu. The topic is rectovaginal fistula, And the question actually we are facing is, do we have any consensus on that worldwide, or is it just an individual approach based on the knowledge of the surgeon or urologist or gynecologist who is treating patients? So yeah, I'm looking forward to the next 2.5 hours, and it's a pleasure for me to announce the first speaker, Jörg Neymeyer, who already gave a talk several times ago for ICRCC, and he will give us his view or experience with treatment of rectovaginal fistulas. Please, Jörg, it's your turn.
Wonderful. Thanks that I can speak here again. And you say it in a good way. What is our part? What is our idea? And have we really a consens to rectovaginal fistula? Yes. Okay. This is a philosophical consideration, and it's difficult to answer. You said it in your entry before. We in Germany have a small consent in the 2012. That was our S3 guidelines. And from this one, I want to see my experience also, and based on it, because something has changed, but a lot of them are not changed. The most problem is classification. A real classification we are not really have. One is on the size, one is on the localization, and one is of the etiology. And also we describe the high and the low fistulas and where we treat it. This is all what you know, etiology, the tables you know also, and the most problem, I see it from the view from a gynecologist and urologist. Most rectovaginal fistula are after obstetrics problems. They're reported after episiotomy or rupture of the sphincter after delivery. But now we have obstetrics rate or a cesarean rate in Germany of 20%. I think in China it's more than 30%. And so that big problems are replaced. The main problem, what we see now in Europe, also in our department and in our hospital, are one part of it. That's why I mark it red. This is a erasing from foreign bodies. And this one is one of our biggest problems after the warning of the FDA in 2011 from mesh repairing with meshes, and they stopped it now in America. We see a lot of mesh erosions later. For this one, we developed a lot of tricks to find also the fistula. Urologist looks like every time with a scope inside of the bladder. This is a typically one. But you can use the scope also for vaginoscopy and for rectoscopy. And it's better than a rectoscope to find, for example, the fistula, the channels of the fistula, and also foreign problems. In the vagina, we find then also the meshes. And the main problem of this is that the recommendation for mesh emplacing from vaginally was stopped now in America. Also in Europe, they say only in the recurrence part you can put meshes, but the most surgeons go now to sacropexy or rectopexy. And the main problem of it was were also the erosions. And we find out that the problem of the erosion developing in sacropexy and rectopexy is the non-resorbable material and the sutures. The fistula is developing not in the same moment, mostly after inserting the mesh. it is coming later because it's a long-term erosion then adapted to the suture. And that's why we recommend every time reducing materials and change to absorbable sutures. You see it here, for example, it's a typically situation then of a mesh erosion from rectum to the vagina in a high part. Mostly it is not a mesh, you see the mesh, but the reason is a suture. And the same is also if you do a rectopexy, you can create in some cases also mesh erosions to the rectum after rectopexy, but then it's also not the mesh, the main reason. This is a suture to fix a mesh. And if you use resorbable materials, for example, then the mesh is outside of the bowel or of the vagina, and then you have a lower chance to create an erosion. That's why we recommend to use Vicryl to fix to the rectum and to the vagina if you use meshes. Also in case if you make a double fixation, rectopexy and sacropexy, for example, and don't use prolanus sutures because they create at first a mini fistula after perforating of the end of the sutures, and mersillanous sutures, for example, promote inflammation. This means mersillane or etibond, for examples, and then you see at the end the mesh, and we say then this is a mesh erosions, but this is a mistake of suture materials. This is, for example, here a sample, long-term erosion of a mesh at the end. You see the mesh, but in one picture, you see it here on the left side in the deepness, there are green sutures. These are the materials of the etibond fixation, and this is the reason why the mesh eroded. And at the end, this is the entry of fistula to the mesh, and then it going up also till to the sacrum. The reason is at the end, then you have to replace all materials. Here you see it also. This is a prolan part. Prolan eroded, and then the mesh is coming behind. The mesh was nice. It was a titanium-coated ultralight mesh. That was not the reason for the erosion. The sutures were the reason for the erosions after sex. They erodated, and then it comes go more to a bigger fistula from the vagina to the sacrum to the bowel. That's why we recommend also in these cases the complete removal of this one. And important is first to find that materials, and to find that materials, it is only possible in MRI to see the fistula channel, but not the meshes and not the tips of the fixating parts with a non-resorbable suture materials. For this one, we recommend then ultrasound. Also, the fistula of secondary of the after rectal resection are really problematic in the urology and gynecology field. That means the stabler problematics. And we will see it then in a part of stabler fixations, then how we can find it. Endosonography, it's a most diagnostic tool now in our department to find something, and the cystoscope, because I said it before, we use a scope for cystoscopy, vaginoscopy, and rectoscopy, and find in that part also the small fistulas. The treatment procedures, this is recommended what you discussed also before. Every surgeon who has his special kind to replace the fistula is in this one, if he is well trained, really the best. And we use the typically advanced endoclosure, and at the end, also in case of recurrence, the Martius flap or the gracilis flap. Only in case of radiotherapy cases, we use an open treatment to put then at the end a omentum wall between the fistula part and divided the bladder, the rectum, and the fistula in a proper way. The question is now: is it a good way to replace fistulas with a robot? The fistulas, rectovaginal fistulas, and the typically one also after stable anastomosis or after endometriosis treatments or mesh erosions, mostly replaced vaginally or transrectally, and only in an abdominal way we recommended to go straight forward without any robot if you have a radiotherapy case, because it's problematic. This is a typically one what we know, the advanced flap repair, simple and easy to do. And I said before, the most important tool what we recommend before we start, and not to say this is a treatment for this surgical way, is the ultrasound. You have two ways to find vagina rectal fistula. Primary, you use the ultrasound transvaginal, but it is more comfortable for a surgeon to go transrectal and not with the endoluminal probe. We use the endfire probe. Why? With the endfire probe, I have a chance also to see the ureter. I see also the cervix at the end, or the vaginal stump. I see the right or the way of the meshes, and I can find also the foreign materials like stapler or the mesh parts. You see it here. This is a typical case. We done it 4 weeks ago. That was endometriosis. The surgeon created end-to-end anastomosis after resection of the endometriosis of the rectum, and what he done is at the end, the typically one is to stable the vagina through the stabler. And what we plan now is a fistula repair. From vaginally, the channel of the fistula is only 3 millimeter. It's not so big, so and it is high at the end of the vagina under the cervix. But if you check it in transrectal ultrasound, you see really exact the white spots. The white spots are the stabler parts. And now if you measure really exact, then you saw it also before, this one is now 1 centimeter open, and from vaginally only 3 millimeters. And this is important for us for planning also the treatment. If you know where is the fistula and how big is it, and that's why I press with the endoluminal probe inside it to mobilize the fistula, to know where I need to mobilize at the end the rectum from the vagina. This is an important part. That's why we use the technique from endoluminal ultrasound with the endfire probe, a typically endfire probe, not a special one. And at the end, if we see the mobilization of that part, we have now a way to reconstruct. In this way, is it 14 millimeter, not 3 millimeter from transvaginally. And this is now the view from transrectally with a cystoscope with fluid. And you see at 12 o'clock, one clip from the stabler, and also at 8 o'clock, also some part of the stabler. And If you see it then with a scope, this is my finger on the other side. Normally, you have only to open it, to flap it from vaginally, but if you see it really exact with a scope, then you know where is also the fixing point of the bowel and how you need to remove it. I do first a guide wire inside, replace it, then or have the channel to make a better preparation. And at the end, I have now a chance also to see better. You see it now at 12 o'clock, the whole way, what I check also before in with the ultrasound, where is the stabler part, and now I have a chance really to resect that, and you see it after closing. It's only one suture here through, but I close it in 3 layers, really exact, and with a scope you have also the control later, and rest also of stabler. This is unproblematic. It's on the other side because the fistula was at 1 o'clock, but the fixing part with the stabler was from the bowel also to the lateral wall of the pelvis. And this is a gadget with ultrasound, what you can find out, where is the fistula and where is a way where you need to mobilize the rectum from the vagina to make a good replacement of the fistula. Otherwise, if you have some forced power with a scar, then the fistula repair will be failed. So you have to mobilize that area before, and these informations you can get only in dynamic ultrasound. For this one, we use a probe. We see also and check also the ureters, because in some cases you can capture also with a stabler the ureter, and also in the Kung Fu technique you can find the stabler parts straight direct connected to the ureter, and you can replace it. To find a fistula, also the way of the fistula, you can use also the ultrasound probe. We called it pumping probe technique. If you use the probe not only to see where is a scar, to where is it fixed or not, if you go forward and backward, you can use the probe also as a pumping probe test. That means you go forward and backward, and you will find then the fistula channel, because you know there is a fistula, but you don't know where is the fistula channel. With a pumping probe test, you can find it with ultrasound without any X-ray in 90% really exact, because during using the probe anterior and posterior, forward and backward like a pump, you can see movement inside of the fistula channel, and you will find it. You see it here. That was a fistula also from the ureter to the vagina and to the rectum. The colleagues suture it, but with a pumping probe test, I see also a fistula again. And if I check the ureter, you see it. The surgeons use, in this case, there was really well trained surgeon, a bad suture, because you have to suture the ureter. This is a recommendation with monocrural and not with PDS. PDS is not a good idea to suture also the bladder or the ureter, because the fistula comes later again, because the suture is so long inside it that for the first 4 weeks the fistula or the destroyed area will be closed, but the suture material have to resorb after 90 days to 240 days, and then a refistula is building to in according to the suture materials. Marz's flap, everybody know, this a simple treatment to make a interponat to the posterior side, also to the vagina, We use it in rare situations. Also, the gracilis flap we use only in case of the recurrence and after radiotherapy. But our most way to reconstruct the radiotherapy or the fistulas after radiotherapy or after oncology cases with radiotherapy, we prefer to make an open treatment and bring an omentum flap through. Next case, 76 years old lady after rectum resection with a temporary Hartmann situation and renewed rectum connection. You see now our technique with a vaginoscopy. This is really simple. You close the vagina with your hands, put then the cystoscope inside of the vagina, and you see at the end the fistula channels, and you see also the bowel part there's coming out, but there's coming also urine out. And what's the problem? In the coloscopy, you can see it very well. After replace the Hartmann situation, after closing the stabler, you see here at the corner also vaginal part inside. They captured totally the vagina and both sides of the ureter. More simple is it if you make a straight direct diagnostic, and so coming also the patients to us. We saw first with a scope inside of the bladder, secondary in the vagina, and at the end with the same scope. And this is now the picture, not with a coloscope, with a cystoscope. And you see it really clear. And the difference is you have a fast track diagnostic to find then from all views, from the gynae view, from urology view, and from the surgeon, from the coloproctology view with one scope. And then you have a better kind to plan at the end. What we done in this case was an open treatment to make a new implantation of both ureters and closing the defect between the bladder and the vagina and make a flap through it. It was not so problematic case, but now it's coming our own mistake at the end. You see it here. They developed a recurrent bladder rectal fistula through according to the catheter tip. The most problem in urology is that you have a typically catheter with a tip, and the tip can then open also your suture at the end of the bladder to the fistula channel. And that's why we recommend a pigtail catheter. This is a better part after closing as to use a typically one. You see it here now. We fill also the part from the rectum part. You see here the anastomotic area to the sigma, and a small way to the bladder in the frontal side. And to open this lady again, it will be a better idea, and it is a really high fistula. We have no chance to make a typically vaginal reconstruction in this one. For these treatments, we recommend now our new method. The new method is to use an instrument to suture it in nodes technique, transurethral and transvaginally. The device, it's really simple. It is only a needle with a self-riding locking needle on left and right side. You can clamp it with a mosquito clamp. From the bladdering side, you can close the fistula straightforward. It is simple. You use a typically laparoscopic tower with CO2, and then you can suture, and with a Roeder node you can close it, or with a von Leffer node, and you go forward. This is the instrument, only the device with a node pusher, grasper you need, and a scissor, and the scope. This is the scope what I described before. Now you see it internally. This is the part. What we do is now we suture it, and in the same way we suture it then also from the bowel side, because both are areas where you can put CO2 inside it. You can go with the scope inside, and at the end you can suture it with suture materials and not from bowel with OTC. You can suture it now from both sides with the same method. You bring then the suture out, make an outside noting, and then you can go forward. You can go forward and closing it with a reader note at the end, and it will be then comfortable in a good way to close it. And at the end, you can capture or cut the suture materials, and all is good. The important part is, I said it before, we suture the bladder with monocryle. Also the rectum part, we close with the same suture with a monocryle. After replacing the fistula, you have to mobilize it. This is the result at the end after 4 weeks. The leakage from the bladder was closed in this technique, and also from the bowel side, it's also closed. And now we are happy, and we can use also this technique for closing the fistula from both sides. If you use in such cases only an OTC clip from one side, the urine will be destroyed, that one, and you have a recurrence fistula, because you have to stop urine then totally. Also, if you have a leakage to the ureter, the urokinase from the urine destroy every anastomosis, and that's why you have to drainage it. You see it here, close carefully, and all will be happy. We can use this technique also in case, I said it, transluminal endoscopic. Next case, also for rectovaginal treatments, or after pouch fistula, for example, to the sacrum. In different cases, I do it with Professor Lauscher together here. You see it here, OTC clip. There was at first inserted at that patient, but you see also under the OTC, the fistula was not totally closed. The OTC is only fixed to the mucosa, and not the fistula was closed. That's why this treatment was failed. And to go after that complicated treatment to the rest bowel in the area where the OTC clip it's fixed, and there's a fistula to the sacrum, it's a problematic treatment. And for this one, what we do is now we go then with a syringe as a placeholder inside that small channel. We use a 10 milliliter syringe, and through that, in a deepness of 10 centimeters, we suture it now with a MSD device, how we do it before. And then at the end, you can take, after you take the needle, you can close it then with a node pusher in the deepness. You bring it forward, and at the end, you can cut the sutures. The difference between suturing and OTC is we have now the chance also transrectally to replace the fistula channel. This is the most part what you need to before you close. You have to mobilize like you do it vaginally or abdominally in a typically surgical way. The fistula, you have to cut the scars and the traction area, and then you have to close it and to suture it, and all will be happy. And you see it here, the marking part, lateral side of the syringe. It is really only in a small room of 1.5 centimeters to suture it. Also in a deepness with that device, it is possible. At the end, we can say heavier consent now. No, it's a philosophical consideration and it's difficult to answer, but it seems so that we can use, and the recommendations also from the German guidelines from 2012, it's mostly in a good way. And the best thing of having a consent is to make a good fistula treatment. This is based on great experiences, a good anamnesis, and a correct diagnosis before you do the treatment, and you need a skilled operator, and the timing is important. Thanks.
Many thanks. I would like to say that the audience from YouTube can use chat for questions. And now, Marko, please. Who would like to ask questions?
Johannes can said also something to it. We work really good together, and the main problem is we have knowledge in every department, from proctology, from gynecology, and also from urology, and we have to know and to train that experience from every other department and give also our ideas to the others. So we will be better and better. This is the main point what we do now in the charity. We create also now a trainee program for both urologists and surgeon, and also for gynecologists, to bring more and more all knowledges together. And then we can say we get a consensus, because the best consensus is how to treat it. And this is what we need to discuss, how we can bring all departments together to one way, and how we can change our trainee programs. This is important, I think so. And this is our new step also for the next 2 years.
Yes, thank you for this excellent talk, Jörg. It was really very interesting. I mean, we did, as you said, some of these operations together. As you said, it's really an interdisciplinary approach. So we need skilled gynecologists and urologists, because it's, these complex fistula really need an experienced coloproctologist, urologist, and gynecologist to have all this experience, and just very great videos which give really a good insight for everyone, and you're a great teacher. And so it's really the next step to what we are working on, to establish these this training program. A few things. So this really to do, like, to use a cystoscope for rectoscopy. I still use my rectoscope because I'm more used to it, but it's really really amazing how good the view is with the cystoscope, as it's showed in the videos. This is really interesting. And also the technique of suturing from inside. Even in this this was the last case you showed, that was side to end anastomosis, and it was a really long side end, like, as you said, 10 centimeters, small fistula. So it was really complicated to suture, but you managed with your self-developed needle, and this really gives us new chances to suture from inside, because the alternative would be to normally you need a laparotomy, because these are very normally really inflamed and scarred tissues. So normally it's really hard to do it minimally invasive. So if you don't manage to do it perineal or from a rectal approach or from a vaginal approach, you really do have to do a laparotomy, which is of course much more troublesome for our patients. So as I said, it's really important to use this interdisciplinary approach, and we you have patients from really all over Germany, even international patients, because Dr. Neymeyer has really a great experience, and he's really known throughout Germany for this, for experience in this complex fistulas.
Johansson, do you do any physiological test or diagnostic before start treatment? I mean, test the function of sphincter. And
what I do,
is it standard?
Yes, it is. Yes, it is standard. But so the main is you can use. This is what I said with Trini program. You can use the ultrasound probe to check also the sphincter in the anterior side. This is what I don't show. I show now how you can find the fistula in the middle part or in the higher way. You can see also the fistulas, so the typically pars fistulas, all kind of fistulas, and also the way. And you can measure also the pressure of the sphincter on it. And for this one, we have a nice gadget, also a simple gadget to measure also the pressure of the sphincter. And we have worldwide to reduce our cost, and we need to be fast and faster in the diagnostic. We have not so much time. The patient is coming, you have to examine this. That's why I show that techniques. The patient is coming, and in 30 minutes or 45 minutes, all will be done, and then we have a diagnosis. We speak together at the end. We make typically diagnostic from a proctology way, MRI, X-ray, and so on. This is what I not stop. I want only to say we have a chance to be faster and easier and compress our diagnostic way in a shorter way with good ultrasound and with good examination. This is what I want to say in this way. Here's something
Yin Lu have question.
Dr. Jin?
Dr. Yin?
Yeah, I have some question for speaker. You give me a very good speak about this very difficult topic. In China, Professor Ji and me interested in this topic. In your speaker, the last section, you just said timing is very important. Yeah, after we find the fistula, maybe after operation or radio damage, how long we can determine operation? It's 1 month, 2 months, or 1 year. So can you give us some suggestion about different conditions for operation?
Yes, we have for this one. That's why you see Johannes' face. We have for this one. The main problem is in a typically normal fistula. We wait for 6 weeks, then you can do all, because then it's totally closed. I said I use every time monocrural. Monocrural, it's holding for 40 days and then it's gone. So you can, then the tissue needs to hold all. That's why we say after 6 weeks, you can do all. If you have a radiotherapy reconstruction, then I wait for it, and then we make a discussion between me and Johannes, for example, when we want to also replace, for example, the enterostoma bag, because if you make a fistula replacement after radiotherapy, it is also recommended to make a ileostoma before, and then we wait in most cases 6 months, and if we are happy both, then we say okay, now it can be. But you know, also you can be the best surgeon worldwide, but radiotherapy, it's a miracle, and it can be destroyed also after this time. So after radiotherapy we wait for 6 months, and then we make a next anastomosis or bring the ileostoma back.
Thank you very much.
Thank you very much, and we have to move on. And I'm glad to welcome Professor Varut Lohsiriwat from Bangkok, the head of coloproctologist department and University of Bangkok. And you are welcome, and first time in our club. And I think you feel comfort with us. You should.
Okay.
Okay.
First of all, I would like to thank the International Colorectal Cancer Club for giving me an opportunity to share with you about the rectovaginal fistula. After low anterior resections, I will talk about the prevention and management. I come from Faculty of Medicine, Sirat Hospital, Mahidol University. Is located in Bangkok. You can see the complex of this building. This is all my hospital. We can accommodate around 2,500 patients at the same time. Okay, we have an opportunity to look back at our data for like 10 years review. You can see the most common cause of rectovaginal fistula in our institutes is radiative injuries, followed by direct invasions of the tumors in the pelvis. But if you focus on the postoperative complications, low anterior resections is the top on the list for the post-op complications. I will give you a short scenario case. It's a 60 years old female with middle rectal cancers. She underwent laparoscopic low anterior resections. This is a referral case. On her history on postoperative day 5, she experienced feces per vaginas, and the surgeon there did the laparoscopic diversions, ileostomies. Fortunately, the pathologists come back only the stage 1. Patient did not need any adjuvant treatment. 3 months later, she underwent transabdominal repair with omental flap. Unfortunately, it fails. She underwent another operations. At this time, they do the transperineal repair with gray-solid flap. But the fistula is still there. So this is around 3 years after the initial treatment. She was referred to my institute. On the examinations, I found anatomistic strictures at 6 centimeters from the anal verge and palpable rectovaginal fistula close to the posterior fornix. Okay, we'll see. This is a common scenario. We do the abdominal approach, temporary approach, and what's next? If you look at the rectovaginal fistula after low anterior resections, it's reported up to 5% of the patients may experience rectovaginal fistula. It's very challenging, as you may appreciate, but it's preventable. And it may complicate the plan of adjuvant treatment if the patient really need. The patients have multiple operations, like I give you some example of the referral case. Of course, it reduces quality of life of the patients, not only because of fecal incontinence, but patients with rectovaginal fistula, they have a sexual dysfunction. Of course, maybe she don't enjoy the sexual activity anymore, and maybe the problem with psychosocial ramifications. Today, we talk about consensus and decision-making algorithm that I will show you at the end of my talk. So what is the risk factor of the RV fistula after low anterior resections? The top factor is very low anastomosis or the large tumor size greater than 5 centimeters, neoadjuvant treatment, and concomitant hysterectomies. So, some risk factor has been mentioned, like the lateral pelvic node resections, bleedings more than 200 mils, malnutrition, and anemia. But I think at the top 4 is the major risk factors. The presentation, of course, patients will experience passage of fetus, or stool per vaginas. Some will experience recurrent vaginitis with foul smells, vaginal discharge. For the physical examinations, normally we do the bimanual palpation at the rectovaginal septums in order to identify the fistulas, to check the intricacies and the diameters or the quality of the colorectal anastomosis. We do the endoscopic examinations, plus or minus the rectals or vaginal contrast study. Sometimes you cannot palpate the fistula. You can use the gauze or put the tampon in the vaginas and use the rectal dye solution like methylene blue or India ink to demonstrate the presence of the rectovaginal fistula. Regarding the etiology, the most common one is the vaginal wall is in the circular staple if you use the circular one, or in the suture if you use the hand seal anastomosis. But it could be secondary to anastomotic leakage. For example, if the patients have anastomotic leakage and have the pelvic corrections drain to the undetected but injured vagina, patients can present with rectal vaginal fistula due to the pelvic abscess as well. But after LAR for rectal cancer, after patient present with rectovaginal fistula, I think you need to have the differential diagnosis of recurrent rectal cancers or radiations injuries to the pelvic organ. In this case, sometimes you need to rule out enterovaginal fistula as well. Otherwise, you can not provide a proper treatment. Regarding classifications, it's a very classic one: low that close to the incoitus, high close to the posterior phonic, middle is somewhere between these 2 points. But another interesting classifications proposed by Japanese surgeons, they divide the fistula based on the radio and endoscopic study. If they see only fistula alone, they classify as a type 1. If they see some dead space between rectums and vaginas, it's called second type. The third one is associated with anastomotic strictures, and the fourth type is have dead space and anastomotic strictures. The purpose of these surgeons, because they suggest that if they have dead space, you need to drain prior to provide any other treatment. But if the patient have anastomotic strictures, this group of patients are really likely to require the aggressive redo LAR or colorectal anastomosis. Regarding management, you can start from conservative treatment, endoscopic therapies, local tissue repair, or radical resections. But several factors need to consider, like host, age, comorbidities, whether they fit to another major surgeries, the fistula size and its locations, if the LAR is for rectal cancer, tumor clearance, stagings, adjuvant treatment, whether patients have the radiations or not. The local tissue qualities, particularly the quality of coronal anastomosis and surrounding tissues, whether the patients have diverting stoma, and of course, surgeon experience and history of previous attempt repair. Conservative treatment can be used in highly selected case. It must be, during the literature review, it must be very small fistula with minimal symptom and no history of pelvic radiations. You can give the patients bowel rest and low residual diet, plus or minus parenteral nutrition and weight. Some reports suggested up to 2 months, you can see whether the fistula is spontaneous heal. So it means that patients may require a special diet and parenteral nutrition over 2 months. But who's know, maybe in the future, we can provide like hyperbaric oxygens or stem cell injections into the fistula if the fistula is really small. It's a food of thought, but it's no data yet. The diverting stoma can lead to spontaneous healing about around 1/4 to 100%, depend how you select the patients. But majority of the fistula after diverting stoma will heal at 6 month time. The predictor of failure is large fistula and the presence of pelvic sepsis. But normally, surgeons will consider diverting stoma, either ileostomy or colostomy, as part of their stepwise surgeries. Regarding endoscopic treatment, we heard an excellent lecture from Professor Myers, but majority is still a case report and case series. You can use either cover stent, fibrin glue, polyglycocactin sheet, endoluminal crypt, and like transanal or transvaginal endoscopic suture, for examples. Regarding local tissue repair, if it are meant to treat with like simple procedure like the endorectal environment flap, I think it's very comfortable for colorectal surgeons to do so. Sometimes you can use the Martius flap for the interposition. In this case, I use the time perineal approach. You can see the probe is still inside, and then you divide the fistula and repair in the separate sutures, one at the rectal size, one is the vaginal size, and then you harvest the fat from labia majors. Normally, for the right-hand surgeons, we use the left labia major fat. And then you preserve the feeder from the inferior pole and try to create the tunnels to put the nice and thick viable tissues between the lip hair. And this is the picture at the end of surgeries. So this perineal procedure like endorectal environment flap or the primary repair with Martius flap interpositions is very good for low to middle fistula. But you need to wait like we discussed that. For me, I wait at least 3 month time, but with radiations maybe up to 6 month times. Normally, you provide patients like state treatment, diverting stoma, and then local tissue repair. I showed the pictures about endorectal environment flap and Martius flap, but you can use other pedicle muscle flap like glycerid or gluteus flap, or even biologic mesh. Regarding the abdominal procedures, I think this is an indication for consider abdominal procedure. First, highlighting rectovaginal fistulas, rectovaginal fistula with strictures, or the refractory rectovaginal fistula, and rectovaginal fistula that have the radiations related. I divide it into two groups because the treatment may be totally different. For the high rectovaginal fistula with the high quality of the tissues like minimal fibrosis, no infections, no evidence of recurrent tumors, you can provide tension-free. You can dissect the fistula out and repair it side by side and provide viable tissue like the well-vascularized omental flap. But the latter three is the other story. Anatomotic strictures, refractories, radiations. In this case, I think you have pretty limited choice, maybe only to do the redo choroidal anastomosis or to redo LAR or even Turnbull-Kilter procedures. The outcome of redo LAR or choroidal anatomy is not that, it's really good to be honest, but you can see the mean operating time is around 4 to 7 hours. Have 50% of the patient will experience complications, 20% will be severe. But if you look at the successful of the healing, it's really high, around 70 to 90%. But you trade off with the more resections, more dissections, loss of neorectums. Patients will have experienced the low anterior resection syndrome. You can see the report, the mean score is around 29. Is on the moderate to severe forms. Major LAR syndrome was reported around 20 to 60%. So I will wrap up my talk with these decisions algorithms for the colorectal fistula after low anterior resections. If the patients experience sepsis, I think you need to approach with sepsis like divergence, pelvic drainage. But if the colorectal anastomosis is non-salvageable, sometimes you need to take down it and make it like the Hartmann procedures. But if the patient did not have any pelvic sepsis, so you need to check the patency of the anastomosis. if the anastomosis is patent, you go one way. If the anastomosis is strictus, most of the patient will need resections and redo anastomosis. But if the anastomosis is patent and the symptom is very minimal, the fistula size is really small, and no history of pelvic radiation, it must be 3 years, you may consider conservative treatment or with or without endoluminal treatment. But if it's not the case, I think fecal diversions is the initial procedure for you to consider, plus or minus endoscopic treatment, local tissue repair with or without tissue interposition. But if the conservative treatment is failed, you like a stepwise approach, fecal diversions approach, local treatment. If the local treatment is failed, so you consider the redo operations. A couple of slides about the preventions. For rectal cancer, normally you transect the rectum 2 centimeters below the distal margins of the tumors. But of course, you need to dissect more than that. You need to separate vaginal from the rectums to make sure that during the dissection, you have a clear view that vagina is not incorporated into the housing. That's why when you pin the staples to the rectum, this is the pelvic wheel. I normally put the tip of the pin just behind the rectal transection line to create a little bit more space between rectums and vaginas. And every time before you file, you need to make sure that there is no vaginal wall in the housings. You need to check to do the vaginal examinations. You ask your assistant on the abdominal face to look at that space as well. Okay, thank you very much for your attention. I'm happy to answer all the questions you might have. Thank you.
Marko, you have a question?
No, actually, yeah, I want to congratulate Varut for this very systematic presentation. Yeah, from a point of colorectal surgeon, I just, yeah, I mean, that's, I think, the way we should go for it, really to the exact history, check the local situation, and then to decide, as he has shown it, on, you know, this decision tree or branches to go for this individualized approach. So I completely agree with his view, and I also would like to emphasize, you know, prevention, especially in rectal cancer surgery. I think that is important, and he mentioned, I think, a very important thing when doing the stapling. You know, often the assistant 1 or 2, least experienced person, you know, is inserting the stapler and shooting the anastomosis. And I think, you know, this examination, and I think maybe we should take more care about this step of the operation. In order to prevent at least, you know, cases of rectovaginal fistula that are based on colorectal anastomosis. That is my opinion.
Thank you.
Varut, I have a question. If you redo operation after low anterior resection, what kind of anastomosis do you use for second redo? It's hand anastomosis or second time stapler?
For the first time, for the low anterior resection, in my institute, we use the side to end colorectal anastomosis. But for the redo operations, it's quite difficult because you lost a lot of bowel length. Normally, when we end up with the end-to-end anastomosis, sometimes you need to do the hand seal anastomosis. So I think end-to-end is the proper reconstruction for the second operations. But in this case, the patient may experience more low anterior resection syndrome because there is no reservoir. Yeah.
Mm-hmm. And how often do you use colonal anastomosis in your routine practice for low rectal cancer? I mean, we know that it's sometimes it's quality of life very low after this kind of anastomosis. And how to separate patient who appropriate for this kind redo anastomosis and when you should avoid this.
Let me check if I hear you clear. How I select the patients to do what? Can you repeat the question again?
Question for low rectal cancer, in case we do colon-anal anastomosis, and what separate what patient appropriate for this all prognostic factors for low quality of life after this.
Yeah. If you consider to do the colon-anal anastomosis, you want to make sure that the sphincter functions prior to surgery is really intact. Otherwise, you can create a so-called perineal colostomy if the patients have poor sphincter functions. But if I do the colon-anal anastomosis, I will do the simple one. Normally, we provide the TNT as a programs. I'm sure many colorectal surgeons shift to the total neoadjuvant treatment already. And then we try not to dissect any part of the internal anal sphincters because some surgeons will do the partial internal anal sphincter resections. I think it's not good unless the patient have a really good external anal sphincter. Otherwise, they will have the slippage or the soilings, particularly during the nighttime.
Okay, thank you. Any other questions? Okay, we don't have question from YouTube, and we can move on. Next speaker is close topic, prevention of rectovaginal fistula after low resection, and Artem Goncharov from Moscow, from Russia. Please.
Hello, dear colleagues. Ni hao, guten Tag. And I would like to thank Andrew and Marko for inviting me for this club. And I would like to thank the previous speaker, Professor Varut and Professor Jörg for brilliant presentation. I totally agree with their thoughts and minds, and I have my role is to show only our small experience in this complicated situation. So I won't talk anymore about the etiology and the epidemiology because everything is said before. We discussed treatment procedure. We do not say about fistula plug and fimbrium glue. We do not use this type of treatment, and I don't know, maybe it's continue to this treatment in some center, but we do not use. Most common is advancement flap repair and Gratzelis flap and Matzes flap tissue interposition. Dissection of the fistula and transabdominal resection is the one of the option in the rectovaginal fistula. So our experience we have in 5 years about less than 1% of rectovaginal fistula after TME surgery or after endometriosis surgery. It's 6 patients, and we think that the risk factors is the rectal cancer and rectocele, neoadjuvant chemoradiation, the large usage of the monopolar coagulation. Three patients were after robotic Da Vinci Sai procedure, anastomotic leakage, pelvic fluid collection, and we find that in our cases, vertical linear stapling line of the rectum with anterior dog ear was the factor of the rectovaginal fistula formation. So treatment procedure, we use 2 types of treatment procedure for high rectovaginal fistula. It's a high anterior resection or maybe endometriosis segmental rectal resection. We do redo resection with maybe pull-through or colonial anastomosis procedure with separate vaginal wall suturing. In low rectovaginal fistula, this option seems is not good because it will be very complicated procedure, and trauma of the sphincter can be more than we want. So we use advancement flap, but with some points. It's the removing of all staples in from the circular or linear stapler, or if there's a dog ear, remove this scar tissue, transvaginal infiltration, dissection of vagina and rectum wall, and separate suturing vicral sutures of vagina and rectum. This was 4 cases, and in 2 cases we added outer fat tissue and stem cells. This fat tissue, we used the abdominal wall fat, performing the fat tissue and adding the stem cells from this patient. We infiltrate around the defect, the rectovaginal wall, and in all cases the patient had the healing of these structures, of these fistulas. The interesting point that the TME surgery is most common and most standardized surgery, but maybe most difficult surgery is the Hartmann reversal procedures. And I want to show you some anecdotal but case in point of the rectovaginal fistula when surgeons without maybe experience or something on performing stapling without checking the vaginal wall. The patient is 68-year-old woman. She had hysterectomy. She had removal of the uterus before, and Hartmann procedure due sigmoid cancer, and open Hartmann reversal. So on the first day, this patient received the fistula and ileostomy. This patient was sent to our center, and we perform open redo of reversal and find out that the sigmoid colon was sutured with staple through the posterior vaginal wall, anterior vaginal wall in the anterior part of the pelvis. So we dissect this the colon, mobilize the rectal stump. It was too long, and connect with the vagina. We separate vagina from this rectal stump, but this rectal stump has a defect, so the option is to dissect this stump and perform standard double stapling anastomosis for this patient. Unfortunately, she lost a lot of rectum with this fistula. We perform anastomosis, and we thought what to do with the good stapled vagina with circular hole, and so we performed some sutures, but not dissect this vagina. And the patient received ileostomy reversal in a few months. So our thoughts and our experience for prevention this type of complication is to good exposure of the vagina. This the complex case of the laparoscopic Hartmann reversal, low rectal stump with no differentiation, and we cannot suture and staple. In this case, we put sponge inside the vagina stump, because this patient had hysterectomy before, and we use stapler to show the rectal stump and performing dissection all around the rectal stump, and look for vagina placement until the end part of the rectal stapling, not to put vagina inside the staple line. So we check the bowel, it's free. We perform splenic flexion mobilization and put vagina wall with 2 hands up and perform stapling only when we see good rectal stump without connection with vagina. So this is the one and main way to prevent of the rectovaginal fistula. And so thank you, and wait for your questions.
And your presentation come back to words of Marko Kornmann about that the just fire stepping, it's very important step. And 10 years ago, I saw the operation, one of the experienced surgeon for rectal cancer, and he do the stepping by yourself and ask you all time do this one. Yes, it's Professor Karanchun, maybe no Russian audience, and all time he does stepping by yourself. Please, yeah.
Yeah, Artem, thank you. Thank you very much for your presentation and for the nice videos you've shown. I think they show difficulties we have, especially in patients after hysterectomy. You have scars, and you know the layer is not clear. you often have a little bit of bleeding, diffuse bleeding. So you use the ultracision or sonicision device, and I think that is also a point I think we have to discuss. Yeah, I try whenever possible just to use scissors, you know, to dissect down the space between ventral lower rectal wall and the vagina, in order to avoid also you know, hypothermic destruction of the vagina. This is also maybe one point we have to think about. And also, you know, not so routine surgeons, I think you should not hesitate to put something into the vagina to guide you during surgery, especially after hysterectomy. Artem has shown it. I think that is also a way to see where you are and where you have to go during your preparation, especially in these difficult cases.
Доброе утро. Доброе утро.
Yeah, may I have a question? Ivanov?
Of course, yes, you can.
Yeah. Thank you. You speak Russia and Germany and Chinese. Thank you very much. But I don't know how to speak in Russia. Good morning or good noon. You give us a very good lectures and tell us how to prevent rectovaginal fistulas. Yeah, it's very important. For us, we all call on rectal surgeon. So sometimes we got some complication with rectal and fistula, vaginal fistula. It is sometimes it's very give a very heavy burden for patient or to surgeon. So you give us a method to prevent it. Very important. I just ask you some question. Can you tell us how do you do to test is liquid or not? In our hospital, we also sometimes endoscopic to find bleeding or leakage, and sometimes it's very simple, just injecting some area in the rectum to find out liquid air balls in the cavity, something like that. Can you tell us you do endoscopic after anastomosis, or shall we do some other ways, or just check sample is so-called is complete, is good or not?
It's a very good question. Thank you. We used all types that you described. We used bubble test or Michelin test, like in Europe said. But bubble test will show you only big defects, and usually you can see it on dissected tissue in the stapler, so it's not complete dissecting tissue. And if you see not complete circular rectal line, so you need to do bubble test. Maybe you will find the leakage. We every time use bubble test when we perform nose surgery with the manual suturing of the rectal stump. With the standard stapler suturing stapling, we do not use it every time. Maybe we're not right. The endoscopy is the good options, and if you have endoscopy devices in your operating room, I think you should do every time endoscopy to look for the bleeding, and the bleeding from the stapler line is the problem. We in this year have about 4 bleedings in this 6 months, and every time we perform endoscopy and clipping of the bleeding points in the anastomosis. I don't know, maybe it's something with staplers, or maybe it's only this fact, but endoscopy is a very, very good option. ICG, I think it's good for checking anastomosis blood supply for surgeon, maybe without experience, without big experience, and sometimes it can show you the problems with blood supply. And endoscopy, we have few situations when we do not like the part of the stapling line, and we perform transanal suturing of these parts with the manual sutures, maybe the dog ears or the crossing of the stapling line to reinforce the anastomosis. So it's a good option if you have the devices for transanal endoscopic surgery and can reinforce the anastomosis transanally.
Thank you very much. You give me just complete answer. Yes, we have a young doctor do endoscopic. Just he is a surgeon, but he gone. So I will ask another young girl doctor, a female doctor, will do this every patient, because in our department, in my operation room, I have endoscopic. So I will do it. And you mentioned the IgG. Yeah, IgG means the bowel blood supplies. What kind of ICG you used? It means your laparoscope must have some dysfunction.
We used laparoscopic ICG, indocyanine intravenous injection, and laparoscopic view of the bowel anastomosis. Sometimes we use laparoscope inside the rectum transanally through the port, transanal port. We put inside laparoscope with ICG function and look inside the blood supply or the points of ICG. And maybe I forget to make a point that if you do vertical stapler line, distal stapling, and you have the dog ear on 12 o'clock on the anterior wall, we try to suture laparoscopically to suture inside this dog ear with the on the anterior wall in woman patient to prevent leakage and rectovaginal fistula formation.
Yeah, it's important. The dog ear is a leakage. After leakage, there are abscess. Then sometimes damage vaginal wall. So later, the patient occurrence some just rectovaginal fistula. And you just tell us, do you have any data about how to use ICG, make sure blood supply is good? Do you have some data. So maybe next time we can invite you give us in China lecture about how to use the ICG to determine the blood supply is good. So osmosis leakage is very low. Do you have any data?
Yes, we have data, and we have some centers. We investigate in Russia this data. It's controversial till now because the ICG sometimes show and we some show the blood insufficient and we change our tactic and move the anastomotic line, but not in all cases. The leakage level is the same in the both group with the ICG test and without ICG test, and we don't have data that shows that ICG is the key for preventing, because a lot of other factors that react on anastomotic leakage. But thanks, I can come to China and to see you and to talk about our experience. Thank you.
Thanks very much.
Many thanks, Artem. Stop show the screen, please. Stop share the screen.
Stop share?
Угу.
Мне кажется, что я за это закончил.
You can see. Okay.
Okay, thank you.
Marko, can you introduce our final report?
Yes, of course. Well, it's a great pleasure for me to introduce Yin Lu and Xiaocai Wu, who are going to show the Chinese experience of management of rectovaginal fistula. Actually, Yin brought up the discussion and the need the International Colorectal Cancer Club should put together a statement about treatment of rectovaginal fistula, and maybe a consensus about that. And I'm really happy now to listen to the presentation of Professor Wu, who is probably going to give the presentation. Please go ahead.
Okay, can you hear me?
Yes, we can hear you. Okay.
Thank you all. Why we need an expert consensus for rectovaginal fistula? I learned a lot from the expert consensus Neymer mentioned before in Germany. Because the different operative techniques were reported on literatures, but none of the studies about operative techniques were randomized, so it is not possible for compare which one is better. So in this expert consensus, the potential statement for inclusion in this consensus were developed by an expert group of colorectal surgeons. All statements were based on literature review or expert suggestions. we using a 5-point Richter scale ranging from strongly disagree to strongly agree. They are strongly agree, neutral, and disagree, and strongly disagree. So the grade system was using to assess the quality of the evidence that we collected. 1 represents strong recommendation, 2 represents weak recommendation. From 1A to 2C, the quality of evidence is degrees granularly. So this is my outline. First of all, I would like to talk about the epidemiology. Statement 1, obstetric trauma is one of the most common causes of rectovaginal fistula. For short, I would like to call it RAFS, followed by IBD and rectal surgery. The evidence level is 1A. The strength of consensus is strongly agreed. There are 2 million people, million women are living with an untreated obstetric fistula in Africa and parts of Asia, up to 100,000 more fistulas develop each year. Here we can see that the data is from a meta-analysis based on national household survey data from 19 sub-Saharan Africa countries. From this data, we can see that the prevalence of vaginal fistula is 3 per 1,000 women. That's a high number, so far more high than developed countries. Statement 2, the major cause for obstetric RAFS in developing countries is prolonged obstructive labors, but in developed countries, obstetric trauma or surgery is the main cause. In developing countries, anterovaginal fistula only 13%, 87% were urovaginal fistula, but in developed countries, most up to 90% is anterovaginal fistula, and only 10% was urovaginal fistulas. The evidence level is 1A. Strength of consensus is strongly agreed. We can see this is a population-based prospective cohort study from Norway. The obstetric vaginal RAFS fistula rate incident was 16.3 per 100,000. For treatment, statement 3, non-operative management is recommended for the initial management for all RAFS, including obstetric RAFS. Statement 4, obstetric RAFS often affect anal sphincter complex. Combined anal sphincter reconstruction is the key to the success of repair surgery. Normally, this repair is transvaginal. In addition to fistula repair, sphincter muscle have to be reconstructed. It is the key to success of obstetric RAFS. The evidence level is 2C for statement 3 and 1C for statement 4. The strength of consensus is agreed. For the complex obstetric RAFS, surgical repair with tissue grafts or grafts is recommended, such as multi-spread. The evidence level is 1C and strength of consensus is agreed. For Crohn's disease-related RAFS, statement 6, Crohn's disease is the most common cause of RAFS in developed societies. We can see that statement 7, imprisonment is effective in short-term closures of RAFS, and maintenance treatment was more effective than placebo in prolonging the RAFS closure. On the baseline, the two groups both have response rate for implasmide. The dark spot is the implasmide. They have longer time for maintenance, prolonging the RAPS closure. Statement A, diverting stoma is recommended for CD-related RAPS due to the CD is in an active period. So we recommend it divesting stoma. The evidence levels 1A for statement 6 and 1B for statement 7, 1C for statement A. Strength of consensus is strongly agreed. RAPS secondary to the rectal resection, statement 9, double stapling was associated with a significant higher risk of RAPS formation compared to single stable techniques. Statement 10, double stapling should be avoided in patients at high risk for developing RAPS after rectal resection, such as those with IBD or other underlying conditions that may predispose them to fistula formation. Statement 11, results from colorectal anastomosis complication often require trans-abdominal approach for repair, such as the stricture of anastomosis or the leakage. Here is a case. The fistula is located at the anterior wall, 6 centimeters from the anal verge. We perform anorectal advancement prep through a transanal endoscopic operation, TPO, plus ileostomy. The patient undergone stoma reversal 3 months later, and then the follow-up, there's no recurrence of fistula or tumor. The evidence levels is 1C for statement 9 to statement 11. The strength of consensus is agreed. So RAPS resulting from local infection. Dr. Neymeyer have mentioned a lot. Statement 12, RAPS resulting from local infection typically caused by anaerobic bacteria such as bacteria brachyuris or Clostridium perfringens. Statement 13, women who have a hysterectomy are at increased risk for developing RAPS due to the local infection. The evidence level is 1C and strength of consensus is agreed. RAPS secondary to radiation therapy. Statement 14, parectomy and modified Bacon procedure or PAC procedure plus stoma is recommended for RAPS secondary to radiation. Here is the patient undergone is a radiation-related RAPS patient. She received Bacon procedure. PAC procedure is also recommended, but patient need stage 2 stoma reversal. The evidence level is 1C. Strength of the consensus is agreed. So RAPS in case of malignancies. Statement 15 for selected carefully selected cases. Total pelvic extension or posterior pelvic extension is recommended. Posterior PPE is not include bladder, and the TPE is include bladder, uterine womb, ovary, and cervix and rectum. The evidence level is 1C. The strength of consensus is agreed. Endorectal advanced fracture is we all very familiar. For most RAPS, advancement plus procedure is with or without sphincteroplasty is recommended for most of the case. We used to do this. Evidence level is 1C and strength of consensus is agree. Transanal closed and transanal minimally invasive surgery, TAMIS. Statement 17, TAMIS for reps repair including advancement flap procedure and total transanal partial rectal resection and reanastomament. Excellent short-term results report, but long-term outcome are not yet known. The evidence level is 1C and strength of consensus is agree. Transvaginal closure. Statement 18. These procedures avoid abdominal surgery as well as providing direct visualization of the entire fistula tract for better suturing accuracy. The intracavitary pressure of the vagina is lower than the rectum, which was considered to be detrimental to hearing. Evidence level is 1C and strength of consensus is agree. Transpernal closures. Statement 19, transpernal closures have been shown to be successful in up to 98% of cases. With small or medium size fistula less than 2 centimeters in diameter, and especially for those low or middle fistulas, may not suitable for all patients, like higher fistula. We can see this is a picture from Dr. Lin. Dr. Lin transected the fistula tract by an endo-GIA. The evidence level is 1C, strength of consensus is agree. The Matthews procedure, statement 20. The procedure is using a pedicle plate of adiposis tissues from the labia majora to cover the cut and close off the fistula. This method is recommended for to compress reps or recurrent reps. The evidence level is 1C, strength of consensus is agree. Gracious interposition, statement 22. Gracious interposition can reach deeper layers of the tissue than other techniques, make it suitable for more complex cases. This picture is kindly provided by Dr. Ping Wang from Nanjing. Evidence level is 1C and strength of consensus is agree. In conclusion, 1. Obstetric trauma contribute to the most common cause of relapse, followed by IBD, rectal surgery. And 2, advancement flap procedure with or without sphincteroplasty is recommended for most reps. Transanal closure is preferred due to the different intracavitary pressures of vagina and rectum. For complex reps, Bacon procedure, Parker procedure, Matthews procedure, or gracious interposition is recommended based on the surgeon's experience. Thank you.
Any question? Dr. Wu, could you share indication for total transanal partial resection? I mean localization of fistula, because for low fistula it's complicated, it seems to me.
For low fistula, it's below the dental line. It's normally they have many kinds of medicate, but in my opinion, below the dental line is low, is what we call low fistula, and above the dental line is truly the truly rectovaginal fistula. For complex fistula is we define complex fistula is recurrent fistula we repair many times and in recurrence or refer from other hospitals. They undergone many surgeries and without also the patient is not healed and recurrent.
I think Marko, please.
Yes, thank you very much for this very systematic presentation you gave us. I have a question regarding your conclusion number 3. You said that the pressure in the rectum is higher compared to the vagina, and that you recommend to do a closure of deep rectovaginal fistulas from the rectal side. I have not so much experience, but when I do it, I, excise the fistula channel, mobilize the parts, and then really close it from the rectal side. But I also close it from the vaginal side. So you can do a repair of both sides. What is your opinion?
Yeah, Dr. Wu, please. Dr. Wu.
Yeah, the pressure is more higher in rectum. Is reported by literature, have been reported by literature, other researchers. In our experience, because we are colorectal surgeons, so we do the surgery from the annals. We familiar with the condition that we repair the fistula from the annals, so we were very familiar with this. And we find that in our centers, we also do the repair the fistula from vagina, but the success rate is more higher than from transanal repair. But there are no RCT research.
Let me speak in this way. Sometimes we repair from Virginia because this patient already had osteoma. So pressure in rectal and Virginia is same. If the patient without osteoma, always repair from rectum side, because rectal side pressure is much higher than Virginia. So if you successful repair rectal rupture, it will be okay. For Virginia, it's okay, it's not nothing. But if you just repair Virginia wall, the rectal wall stitcher is not very good. So the patient will recurrence very soon. So at the very beginning, we used the CEM. The instrument is developed by Germany. I first used in China. I use this for repair the Rectovaginal Fistula. I give a lecture in Peking. A lot of doctors do not believe it can do in this treatment because it's very difficult. It's chopsticks technique, choptics definite. Sometimes it's difficult to image to stitch. But when I give a video to them, they will they will believe us we can do in this way. So for me, I spend nearly 30 years to deal with the rectovaginal fistula. It's very difficult for us. Just very for radio damage and IBD disease is very difficult. Okay.
Yeah, thank you very much for that answer. So your opinion is the additional repair or closure of the vaginal wall is not necessary, because if you close the rectal wall, the vagina will heal.
Dr. Wu, I have a question about primary obstetric fistula. According to your presentation, recommendation with flat and sometimes to sphincteroplastic. And what indication based case when you use sphincteroplastic type of sphincteroplastic? And it seems to me for consensus in future we should separate these cases, because it's rather different patients who need sphincteroplastic and who easy cases. What do you think?
Let me repeat your question. You mean how to define the not compressed case?
Mm-hmm.
Right.
I mean, what indication for combination flat with sphincteroplastic, and what test you do before operation to for based with you for your decision to do sphincteroplastic?
Yeah, for those in most cases we do the advancement prep for most fistula, except for those who have the radiation, who have the structure of the anastomose, and those who have the recurrence, and those who have the diameter larger than 2 centimeters.
I see. Anybody would like to ask question? Okay. Maybe we can go to conclusion. Today is Saturday, and maybe Yin Lu start conclusion. Okay.
Maybe I can start.
Mm-hmm.
Actually, I think the topic today, rectovaginal fistula, all speakers have shown that I think this is an important topic in all countries around the world. And that we have different causes. Maybe in the developing countries it's due to birth, but in the more developed countries, especially colon and rectal cancer surgeons, they are facing these problems after rectal cancer surgery, especially including neoadjuvant radiation. All around the world, we have a problem with inflammatory bowel disease can cause these problems. Jörg has shown German view with very nice videos, doing a lot of minimal invasive diagnostic and therapeutic approaches. I think this is a good way to do it. Varut has shown a very nice systematic overview, also giving views of conservative treatment, stoma placement, and when to do the operation early on, 6 weeks after diagnosis, or wait longer, maybe after radiation. Artem has shown very nice videos, also introducing, you know, the ICG question. Should we check the blood supply for healing of the anastomosis, and also focused on the double stapling. I think here we should really take care, especially when doing rectal cancer anastomosis, to avoid you know, the front dog ear facing to the vagina. And then Xiaocai Wu and Yin Lu, I think, yeah, they really showed in a very systematic way again the evidence-based recommendations for the treatment of rectovaginal fistula. So I'm really happy because I got a really updated overview on this topic. And from my point of view, luckily we had a neurologist. We did not have a gynecologist that included in this session. I think we also have to think after diagnosis of such rectovaginal fistulas to look at an interdisciplinary approach, you know, depending on what organs are involved. We really consult our local gynecologists and maybe, you know, really do more often come to doing a combined treatment together, as you have shown it, Johannes, in for Berlin. That not only the rectal cancer surgeon is doing it transanal, but maybe we have the chance to invite the gynecologist to check the vaginal side.
Yeah.
I think that is probably important also in the future. We learn from each other different techniques, surgerying vagina, doing the Martius flaps. I think there are several ways how we can, you know, increase our knowledge and interdisciplinary knowledge to get the results in the future and find more individualized approaches or optimize these approaches for these patients, because every patient, I think, is very different when we look at etiology. I think that is my conclusion or summary of this topic. And yeah, I want to thank all speakers and discussants. It was a very nice session. Thank you very much.
Many thanks. Professor Varut, are you with us?
I want to say things. Thank you very much because this topic I want to discuss. I asked Dr. Ivanov and Kornmann. We have some spend 2 or 3 hours discussion about this special question. And I got four speakers give us a very deep impression, and we can ask Professor Wu send email to everybody and to check out, put your idea, your message on the paper, so we can maybe we can got some common sense. Is okay? I will ask Dr. Wu to send email this article to everybody. Okay?
Yeah, I think that is very important, and then I think we really can, set together a consensus statement, including the speakers and discussions of today. I think that would be a very good idea. Yeah.
I already sent this paper to Professor G. Professor G asked me give this speech, then send to everybody. Professor G.
Yeah. So, thank you very much for the four speakers and all the the team discussions. I think it's very interesting this afternoon, because the main purpose of our the small meeting, want to set up a consensus or something like the guidelines. I think it's very necessary. That if the consensus named as ICRCC, our club, internationally, that must be very interesting, because at the moment we didn't see many some important consensus or the guidelines about rectovaginal fistulas. So Jörg showed that's the German S3 guidelines. There was a small parts about the fistulas. I think it published about 11 years ago. Some of them, I think, like the Norway have something changed, because a lot of the mesh used in vagina department, vagina, a lot of erosions. So omitted such a part of the infertility. But Jörg mentioned about some cases. I think it's very, very good. We have to pay much attention to some new etiologies. So this is very important. And may I have some suggestions? I think making a guideline or consensus actually is a very complex, very tough, a lot of work. So we have some experience international about incisional hernia. I think leading by Professor Bittner. That's really international experts who work together. So it takes a long time. So first we have to review the article, and then to point out some questions. And about the questions, of course, the questions very red point, hot point. This question, that means you have to answer, to find some evidence base to support. I think Professor Ying's teams have already worked a lot in this, because the statement, I think maybe 20 or 18 statement, and also there are some recommendation, agree or disagree. You have already did some work. This is very basic, but we have to based on the German. I think the German S3 guidelines is very interesting. It's also very important. We can, based on these S3 guidelines, and also I remember in 2016 in Disease Colon and Rectal, the journal published the clinical practice of. There is another papers, but it's still a little bit long time. So that I think we can logically. To find some very important items, the disagreement, statement, and disagree or agree. This is very good. I think Professor Yin Wu should send the papers, the draft, the manuscript to the. I think not only our groups, but we can expand some some other experts like urologist or gynecologist, not only our abdominal surgeons. So this is very important because some new problems like mesh erosions, we only have very few knowledge, but we cannot find some, very strongly statement to support such things. Of course, the Jörg and Varut has shown a very big group of the cases. I think in Thailand, Bangkok, they have more than 100 cases. Yeah, it's more. I think it's very interesting, very important data. Maybe we can find, according to your lectures and some of the skills, technologies, and we can work together. Okay, to have to find out some modifications, and then maybe we need maybe the next or the 2 times or 3 times, the meetings for finish this international consensus or the guidelines. Okay, so I think it's a good beginning. It's a very good beginning for us because Professor Yin already very roughly the manuscript about the consensus. Yeah. So I personally suggested these international guidelines or consensus may be named as ICRCC. Comment. ICRCC, we worked out to have a consensus is our work. Yeah, it's our also is our job. Yeah.
Okay, many thanks, Professor Varut. Can you speak? Oh no, you're driving.
I can speak. Yeah. If you think the consensus will name as ICR, I think it should focus on cancer surgeries, because otherwise you will see a lot of obstetric sphincter, obstetric related rectovaginal fistula or Crohn's disease, because we can narrow the scope and we can have in-depth and maybe a very good level of evidence. Yes, and reference as a consensus as we have many strong group from multinationals. Yeah, I think I simply suggest that we just focus on the RV fistula that related to surgery. Yeah, due to cancer surgery. Yeah, thank you.
Many thanks. I share the contact with Dr. Wu, all participants of this seminar, to start consensus, and it seems to me it's just first step for this difficult topic, and we should discuss more and more detailed. Maybe we need after preparing work the offline meeting to close the contact and more detailed for different cases. Many thanks all speakers that your day off be with us, and maybe Marko, you close the today meeting.
Yes, Kornmann, can we got some more convenient to communication? WeChat is very convenient. Yeah, I think we can use WeChat as a communication tool, so we can communicate very easily use WeChat. So you know how to use the WeChat. So you tell your colleague, and also maybe Ivanov, I can tell you how to use WeChat. It's very convenient. WeChat. It's very convenient.
It's very convenient, actually.
Yeah, so Ivanov, I will ask Dr. Wu tell you how to use WeChat, so we can WeChat. It's very convenient. Maybe Thailand Professor Varut, is my pronunciation is good or Varut? I don't know.
Varut.
You drive
Varut.
carefully.
Thailand.
So I will ask Dr. Wu to tell all of you to how to use and the WeChat, and Kornmann already know how to use it. Okay.
Many thanks. See you next time. We connected with Presidium and decide time and topic for next and announce a little bit later. Many thanks all.
Okay. Bye.
Bye.
Bye. Take care.
See you.
Bye. Thanks.
Надо завершить.